I want to introduce our next speaker. Our next speaker is the absolutely amazing Zoe Harris. She is the CEO of My Future Care, My Care Matters, and I want to welcome her up to the stage. Thank you, Zoe.
Thank you, Danny. Good morning, everybody. Well, as Danny said, my name is Zoe Harris. I'm the founder of a social enterprise called My Care Matters, and we run a project called My Future Care. Danny and Claire have asked me to talk to you today about what do we want, and then on from that, how do we achieve it? So there's a quick answer to the first part that I think you're all going to agree with. What we want is to live our best life possible, and then, when our time comes, to have a good death. The second bit, how do we achieve it, I'll go into in a minute, and a bit of a spoiler alert, you've heard some of it for sure from this morning's fabulous presentations. But first, I'd like to take you back 14 years to explain how I came to some conclusions that I will then share with you. The inspiration for this work was my late husband, Jeff, who lived with dementia. I cared for Jeff for about 5 years until he had to move to a care home for what turned out to be the final 13 months of his life. During that time, I saw how mistakes would happen because the people caring for him knew nothing about his needs and preferences, nothing about the things that mattered to him. Yes, there was a care plan. In fact, it was over 100 pages long. And it was tucked away in the office, which you can imagine was impractical for busy staff trying to look after not only Jeff, but 29 other people in that care home as well. So I developed a wall chart. It went on to be called the Remember I'm Me Care Chart, to share the things that I knew Jeff would have talked about if he'd been able. All I was trying to do was help busy carers support Jeff and to help them develop a relationship with him, which would be impossible if they knew nothing about him. When the care home managers saw that first chart and asked for some more for her other residents, I realized that this simple tool had the potential to help thousands of other people in a similar position to Jeff, unable to communicate and being cared for by people unaware of their needs and preferences. To my amazement, in these days of expecting every problem to have a high-tech solution, care homes still want these charts. And you know what? There is still no more reliable way than a chart on the wall to ensure that everyone who is interacting with the person has access to an at-a-glance snapshot of their needs and preferences. As one care home manager put it to me, we use electronic care planning software to demonstrate to the inspectors that we collect and hold appropriate information about a person, and also for crunching the numbers. But we use your charts to ensure that everyone going into a person's room has access to the information that they then need to engage with that person. Long story short, variations of that original chart have gone on to be adopted by over 1,400 care homes throughout the UK. It also attracted the interest of hospitals. But as much as I could see how vital it was to ensure that a person's needs and preferences were available to hospital staff just as much as they were in care homes, we needed to find a way to ensure that that information was available immediately, not just when family members came in to provide the information that then could go onto the chart. So that was when we developed an online tool called the My Care Matters profile, where people can input information about themselves or on behalf of someone they care for, and make it available to anybody who's got their unique My Care Matters code, their name, and date of birth. The reality is that printing it out still, for now, has the best chance of it being seen. But at least then, if the printout does go missing, the information can be viewed online, and of course it can be reprinted and updated or amended whenever necessary. It became clear that it was so much better if we could get people to create their profiles in advance of a hospital stay. And even more so, if people could do it for themselves and not wait for a crisis where they then may or may not be able to communicate their own needs. That might be temporary or permanently, but then somebody else is going to have to create their profile for them and perhaps just have best guesses as to what they'd have wanted to put on that profile. We were trialling the profiles with an NHS trust in 2018, where they were also looking into why more people were not doing advanced care planning. And we saw how filling in a My Care Matters profile with either the patient or their family was a great way of leading the subject onto what they might want in the future. For example, there's a place for writing down the important people in your life. So that provides an opportunity to ask if one of them might be the person they'd like to speak on their behalf, if they were unable to communicate. In other words, to give that person power of attorney. We ran some workshops with that trust and then did 2 further years of research to understand the barriers preventing people from making plans for their future care and end of life, which pretty much boiled down to these. So lack of clarity, it's about not understanding the options available, what it is we should actually be doing. And that goes for healthcare professionals as much as everyone else. It was a key factor behind the reluctance of staff to initiate the conversation. Confusion as to what document does what. One of the classics is understanding the difference between an advanced statement and an advanced decision. And then the reluctance to discuss death and dying. We know that as a society, we struggle to talk openly about death. Even to use the word itself is a problem for some. There is a sense for some people that talking about it is going to make it more likely to happen. But of course, it is going to happen. So we need to find ways to dispel that reluctance, which then may well stem from fear. And that fear may be felt either by the individual or by the people around them. Either way, it means the conversation gets shut down. And the longer it's left, the more difficult it becomes. And by that I mean emotionally. It seems the closer we get to facing our own mortality, the more difficult it is for some of us to acknowledge it and make plans. So as a result of that research, we'd learned how recording and sharing our non-medical needs and preferences is just one of the things that we should all be doing as we approach later life, or we may be living with a life-limiting diagnosis. Also, that the conversation needs to happen earlier and not in the middle of a crisis, which may or may not be life-threatening. It was great that we were engaging with people in that trust hospital, which then kicked off our subsequent research. But is sitting on someone's hospital bed really the best time to be asking them for the first time to consider the things that are important to them? So back to that question of how to achieve our best life possible and a good death. And there's a one-word answer to that, and you have heard it this morning. The answer, of course, is through knowledge. Only when we have knowledge of what future care planning is, what's involved, can we then become aware of the choices available to us. And with that choice comes control. And control gives us well-being, improved well-being. That helps us to live the best life possible that we can, and eventually to improve our chances of having a good death. And there's another outcome gained once we acquire knowledge. We know fear is one of the reasons people don't make plans. And that's because we tend to fear things we don't know or understand. As Debsis Meerder, the American physician, philosopher, and author, says, fear comes from the lack of knowledge and a state of ignorance. The best remedy for fear is to gain knowledge. So the more we know about a topic, the less we are likely to fear it. As Sami and Sian say in their excellent book, Hope for the Best, Plan for the Rest, information is the best medicine. And we've all heard the Francis Bacon quote, knowledge is power, something he said back in 1597. We owe it to ourselves to be aware of the options and the choices available to us, to take a proactive role in our care and our future, to be empowered and have some level of control over events in the future when we may have lost the capacity to speak for ourselves. And when is the right time to start informing ourselves, having these conversations, making those decisions? Again, it's a simple one-word answer. The only sensible response to that question is now. If we want to live our best life possible, to have the best death possible, we can't leave it to chance. There is a saying that it's always too soon until it's too late. Apparently, that's what almost 60% of people over 75 think, that it's too soon. We always think that we have time to sort things out until suddenly we don't. And we have to remember that none of us knows what's around the corner. So I don't think you should be too worried about this particular scenario. But there is one thing that we can be absolutely sure of, and that is that our life is going to come to an end. We just don't know when or how. There's a school of thought that advanced care planning is something that should happen in someone's final year of life. In my view, that sets up entirely the wrong ethos. This is not something that should be first looked at when we're recognizably nearing the end of our life. It immediately links it to something negative, when if it's done early enough, we can experience that sense of control and improved well-being much sooner. And certainly for people living with conditions like dementia, they may live for several years without the ability to communicate their wishes. So it absolutely needs to be done as early as possible for them to have any meaningful input. So it's not about how old someone is or their state of health. There are some things that every adult should do to prepare for the future. And how much easier it is to have that conversation at a time when the concept of death is just that, just a concept. Studies have shown that family members may be reluctant to raise the topic with a frail relative because it suggests they're thinking the person may be nearing the end of their life. Have the conversation when we're fit and healthy, and that issue disappears. Once people realize that it's not about their age or whether they're living with a life-limiting condition, it's a much easier topic to approach, a much easier conversation to have. So we may not know how or when we're going to die, but there are things that we do know. We know, for example, that we're likely to have at least one hospital admission in the year before we die. The average is 3.5. Maybe some of those admissions are not in our best interest or strictly necessary. But if we haven't had the opportunity to consider whether and at which point we might want, for example, to refuse proactive treatment and prefer to stay at home, we're more likely to end up in hospital. For that reason alone, these conversations need to take place sooner and definitely not to be kept for a time of crisis. Of course, we might change our minds, and that's fine. Once the ice has been broken, it's a much easier conversation to return to in the coming years. So let me tell you what we did with all that learning. During our research, we'd found a lot of great materials, both online and in printed form, but none that brought it all together. So we produced the My Future Care Handbook. It's a one-stop shop for all things related to later life. It's been described as a gentle walkthrough of all the things that we should be thinking about as we approach later life. And the intention is to encourage people to think about and make decisions around their future and end of life much earlier than tends to be the case. So the approach we've taken is to make it relevant even to those people who may not feel that they're ready or need to discuss their later life care or their end of life. So we talk as much about living well as we do dying well. We thought hard about how people might be motivated to make a start. One small thing about it is that we provide a pen with each book. As one of our first reviewers said, it was so easy to just open it up, get drawn in, and start writing. And almost without realizing it, you've started the process. That, by the way, is one of the reasons we've deliberately made it a printed resource as opposed to being online, which is not to say that we shan't take it online or certain parts of it anyway in the future, but we get lots of feedback that it's a pleasure to have a tangible document to hold and work through. And also because there are still almost 6 million people over 65 who are unable or unwilling to use the internet, and we didn't want that to be a barrier to them being able to acquire the knowledge they need in order to get that sense of control over their future. We provide QR codes in many of the sections to enable people to access online resources when they're happy and able to do so. People choose to make a start in all sorts of ways. A bucket list may sound fairly innocuous, but it can really help people to start thinking about what is important to them. And a playlist of the music you might like to listen to if you're unwell. It can be a great conversation starter and an enjoyable activity if you're doing this with someone else. Hearing is thought to be the last sense to go in the dying process, and I've heard some beautiful stories of people getting a final smile from their loved one when a piece of music is played that they know and love. And it's worth remembering that all of these things are useful in the event of an unplanned stay in hospital, even if it's not life-threatening, and you have many more years of life ahead of you. So again, future care planning is about living well, not just dying well. And adopting that mindset makes it an easier subject to approach. So back to the handbook. People like to start at the beginning. Some people like to start at the beginning and work their way through. Others take a more scattergun approach and dip in and out. For people not sure where to start, we've created a color coding system that can help them prioritize the tasks that may be most appropriate or urgent according to their situation. Some will want to cut to the chase and get on with the core legal documents. So for all of these and the other documents and decisions available, we provide forms to fill in if they're not going online, or again, as I said, QR codes that can take them to online resources such as Compassion in Dying and the Power of Attorney page on the gov.uk website and many others. And then there's a variety of fact sheets as well on the different kinds of housing and care that's available for people in later life, tips on healthy eating and keeping fit, and we touch on financial support and planning as well. This is something that we encourage people to look at early in the process. It's a list of all things covered in the handbook. I don't know if you can actually read the list there. And it's a place that people can go to tick off the things they've already got in place, they've decided they don't want or need to do, or to identify the things that are still outstanding. And then, of course, just as important as doing the tasks is having the conversation and sharing your decisions. We need to ensure that our family members and friends know what our wishes are, even if that conversation can be a challenging one for some or all of those involved. And we absolutely need to be sure that the people we appoint to speak on our behalf really know what we'd like to have happen in the event that we can't communicate for ourselves. I'm sure you've heard it said that doing our future care planning is a gift for your family. They will be truly grateful and when and if the time comes you need their support and you've already set out what you want. Certainly I felt that way when my late mother told me she'd written out what she wanted for her funeral. She had COPD, and as it started to get worse, she'd made plans. How detailed some of those plans were, I wasn't aware of until after she died. And I shall be grateful forever that she left a full list of people to inform, their contact details, the kind of funeral she wanted, including her choice of hymns and what she wanted us to do with her ashes. The only thing she could have done better was to leave those instructions in a more obvious place. She had told me she'd written them down, so I searched high and low in her flat until finally I came across a few scrappy bits of paper in the back of her previous year's diary. So it's really important that people not only think about these things and write down their preferences, but that they're accessible when needed. And the handbook has got a lot of advice on that too. As user-friendly and easy to use as the handbook is, even that isn't enough to shift some people from thinking about it to getting on and doing something about it. Lots of us are expert procrastinators. We find convincing reasons for not getting on with it, and we need a nudge. I learned a great word for this recently. What we're doing is quiddling, busying ourselves with trivial tasks as a way of avoiding the important ones. We are all such good quiddlers, and I can hear you can recognize that in yourselves. There were lots of people who were very generous with their time and did some in-depth reviewing of the first version of the handbook back in 2020. But I noticed that many of them only made a start once we had a date in the diary to speak about it. Then there was an urgency, a deadline. It meant they needed to get on with it. They admitted they needed that nudge to open up the book and make a start. Sometimes they get stuck at a particular point. I'd need to give them permission to move on, do something else, maybe come back to that later. So we experimented with offering people an opportunity to have a friendly chat via Zoom or on the phone, this was during COVID, with a trained volunteer buddy. We used a coaching style to help people think through their plans for later life, and we gave them a gentle nudge when they needed it to put their thoughts into action. With a date in the diary for a follow-up call, it would have been rude not to show up. And if they and their buddy had agreed a set of actions that were going to be done before that next conversation, it gave them the impetus to get on and do them. We didn't offer advice, but we did signpost to services as appropriate when a greater level of support and advice might be necessary and appropriate. We ran a pilot, and we recorded some excellent outcomes. Unsurprisingly, the number of documents increased from before the intervention to after. Participants also reported a significant improvement in their quality of life, and their well-being score improved through feeling better informed and having things in place. Because I'm sure, as you're well aware, good mental well-being is not just some fluffy, nice-to-have outcome. Positive feelings bolster the immune system and lead to fewer cardiovascular problems, whereas anxiety and depression are linked to poorer health outcomes and conditions such as inflammation. But as a small organization, we could only support relatively few numbers of people, and an online service, of course, doesn't suit everyone. So we are now working with organizations whose clients, members, patients, whatever they are, would benefit from making plans for their later and end of life. We offer online training for their staff or volunteers to give them the confidence to initiate and support a conversation around future care planning. And they're using the handbook as a source of information and structure for that conversation. So because the handbook has all the information that they need, they don't need to become advanced care planning experts. But as I say, it just gives them that confidence to support that person going through the process. And then they're free to provide that support in whatever way suits them best. So we've got organizations running group sessions, drop-ins, one-to-one meetings, phone calls, or a combination of variation of all of those. These are just some of the organizations, and I know there's a couple represented here, that we're already working with at either local, regional, or national level. Hopefully you've already seen that handbooks are available to buy here or available online or Amazon. We've got vastly reduced prices if your organization wants to buy them in bulk. And we welcome inquirers from charities, community organizations, groups who'd like to use the handbook with the people they support. And we're happy to supply handbooks also with an organization's own branding if that's something that's of interest. So, to sum up, it's all about living well. Think about future care planning as a way to get things in place for living a good life, not just having a good death. Knowledge is power. We're empowered to make choices, and we gain a sense of control when we're aware of the decisions and options available to us. The time to do it is now. Remember that saying, it's always too soon until it's too late. Enjoy the process. Yes, one or two of these tasks might be a bit of a grind, but actually some can be fun, and there's always that buzz of achievement as you tick off the tasks. And then get on with living your life. As we say on our strapline, it's all about planning for tomorrow and living for today. Thank you.
Thank you so much, Zoe. And I've been on Zoe's buddy training, and it's amazing. And you probably hear me banging on about the Future Care Handbook all the time because I think it's a fabulous resource. So before we finish, is there any questions? We've got 5 minutes or so for questions. Anyone on the live stream? No? No? Oh, Liz. Oh, I'm a runner.
Zoe, thank you for that. That was really interesting. I used to be a GP in another life, and I really like your chart that you said you designed for your husband. Yeah. Do the care homes ever copy that and send it in if the person is unfortunate enough to need a hospital admission? Just thinking how valuable it would be. Now I work as a volunteer in the hospital.
Absolutely. Yes, they do. They don't just copy the big thing. What we've got is variation. So we've got a size, we call it the file size version, you know, it's a while since I've looked now, and also a pocket chart. The idea of that is to stand by one's bedside, so you can transfer the information from the chart. And other people have other forms that they use already to send into hospital, but the pocket chart is available there as well, which shows the same symbols.
Yeah, that's great. Thank you.
Okay.
Thank you, Liz, for that question. Really good. Anybody else before we...
Got a question online.
Oh, the question at the back. Oh, Bill, blimey. Sorry.
Yeah, pass them back. It's okay.
Oh, you could have passed them out. Oh, yeah, okay.
Right, hi.
Annika Rice, I'm coming back down.
Hi there. Hi. That was a great talk. Thanks a lot.
Thank
Just checking on one of the slides, the last slides, it said that there was free funding for handbooks according to funding in particular areas. Just
Yes, at the moment we've got funding where we can provide free handbooks for everyone supported and also the people that we're training as well in the whole of Sussex and Kent. We're working on other areas, but we'd be very open to partnering with people who want to do a fundraising round and be a partner in that funding application if that's of interest.
Okay.
But we can't, at the moment, promise to supply free handbooks to every area. Love to be able to do it, so
I'll be in
this
touch.
space.
All right, thanks a lot. Thanks.
Thank you. There is, Danny, just one thing I
Hey,
realised
Danny,
I didn't really
sorry.
touch on.
Sorry, there is one online now. Questions just come in online. Question is, do the handbooks come in different languages?
Oh, wouldn't that be nice? Not yet. There's a lot of work to do, I think, to achieve that. And if somebody had the funding available for us to do that, we would love to go down that path, but not yet. I was just going to say also, I didn't touch on the fact that we're now building a fantastic community of people whose staff and volunteers that we have trained or they've come on awareness courses, and we're well over 100 people now who then come together occasionally to have conversations. It's online because they are all around the country, and to do various top-up and further upskilling sessions as well. So that's another benefit of the things subsequent to the training.
Yeah. So definitely, if anyone's interested in the free training, please do let Zoe know. I'll be sending out all the details. Definitely, Bill, I think Compassionate Companions would be definitely up for that. Sorry. But yes, thank you very much, Zoe. Thank you.
Thank you very much.
Thank you so much, Zoe. Like I said, love the handbook. Think it's a fabulous tool, great resource. So next, I would love to welcome to the stage. Oh, it's got a ghost in there. It's going forward. I'd love to welcome to the stage Usha Grieve from Compassion in Dying.
Hi everybody, it's absolutely lovely to be here. And I always think they don't make lecterns for short people, so I might stand over here. So I work for a national charity called Compassion in Dying, and I'm going to talk to you today very specifically about advanced decisions to refuse treatment. And I'm going to cover just generally what they are and what the law says about them, why people make them, really importantly, how they can help, so the difference that they can make to somebody's end-of-life experience and their quality of life in the present as well. I'm going to touch on barriers for the public and for professionals around advanced decisions, talk about how you make one, go through some of the free templates that are available. And I'll keep coming back to this, but what I really want everyone to take away from this, and generally when thinking about advanced care planning, is that talking about your end-of-life wishes is a great starting point, but recording them is really, really important for reasons that I will go into. I'll start by talking a bit about what we do, so you can understand why I'm here. So like I said, we're a national charity, and we help people to make informed decisions about their end-of-life treatment and their end-of-life care. And we're really all about ensuring that what matters to the person informs their end-of-life decisions. And we help people to have conversations, to record their wishes, and importantly, to revisit their wishes whenever they want to. And we do that through a number of different services. So we have a nurse-led information line. We also have an online advanced decision and advanced care planning service. And we have a specialist service which provides in-depth casework to people who need help to advocate for their loved one's wishes when their loved one lacks capacity. And you can see here that the NHS links to our forms, and we're the UK's leading provider of advanced decisions. People over there can't see me. So we've supported 54,000 people to make advanced decisions to refuse treatment to date. And there's a huge amount left to do. And I think this is really important to bear in mind. And Zoe touched on the amount of people making LPAs earlier, but there's a massive disconnect between the amount of people who have a strong desire or a strong feeling about what they would or wouldn't want at the end of life. So we know that 76% of people have a strong opinion about their end-of-life care. And also, and I think this is really interesting, that only 10% of people, when asked, say they would want their doctor to make the final decision about their treatment. And actually, they would rather make that decision themselves, nominate somebody that they trust to make that decision, or have expressed and recorded their wishes in advance. But only 7% of people have recorded their end-of-life wishes in either an LPA for health and welfare or an advanced decision to refuse treatment. So there's this figuring out how to solve the problem of this disconnect is really all about what we do at Compassionate Dying. So what is an advanced decision? And you can see here this is a sort of the first page of our template advanced decision form. I think we all know that there's just an unhelpful amount of terms for the same thing when it comes to advanced care planning. So people call advanced decisions advanced directives, the legal name is advanced decision to refuse treatment, and the public call them living wills. And we know this. You can look at the Google stats for how many people search for the term living will over advanced decision. So if you're talking to somebody, talking to a patient, they'll generally have an understanding of what the term living will is more than they will advanced decision. And it's a form, really, that lets you refuse any medical treatments that you don't want to have in the future. And it will only come into effect if you lack capacity to make that decision for yourself. And you can use it to refuse any medical treatment, and that includes life-sustaining treatment. So things like CPR, clinically assisted nutrition and hydration, such as a PEG feed or an NG tube, or mechanical ventilation. And I'm sure some of you will know this already. I think it's really important to this underpins everything that I'm going to talk about. It's important to talk about what the law says about advanced decisions. So in England and Wales, the Mental Capacity Act says that advanced decisions are legally binding if they meet certain requirements. And that's to do with it being valid and applicable. And this means that it has the same effect as you or I making a decision about treatment right now. So everybody in this room has the right to refuse medical treatment. And if a treatment's recommended, you have to give your consent for that treatment. And what advanced decisions do is it allows people to retain that decision-making power when they can't speak for themselves, so when they can't make or communicate a decision. And what that means is that if somebody lacks capacity and they need a treatment and they have an advanced decision that covers that treatment, then there's no best interest decision-making process, and the advanced decision is followed as long as it meets the certain criteria that I'll talk about in a minute. And those criteria, just to sort of go through them very quickly, so I feel like this is perhaps the dullest bit of my presentation. So it needs to be made by somebody who's 18 and has capacity to make the decisions in question. And I should say that in my talk, I'm going to talk specifically about advanced decisions that refuse life-sustaining treatment, because that's what the people who come to us for support always want to do. So if an advanced decision is refusing life-sustaining treatment, it has to be in writing, it has to be signed and witnessed, it has to specify the treatments that need to be refused and the situations in which you would want that to come into effect. And don't get bogged down in all of this, because spoiler alert, I will, towards the end of my talk, go through some of the templates that exist that do a lot of the hard work in writing those refusals of treatment for you. And it has to very explicitly say, I want this to take effect even if my life is at risk or shortened as a result. And really importantly, I think with advanced decisions, they can have like a bit of a bad rep when it comes to how people view them. And I think that's because they're often seen as quite tricky. They're seen as a legal document, and they're very, very serious, and they contain very serious decisions. But what I really want to bring it back to is why people make them. So I'm going to start with this bottom bullet in the purple box. Most of the people who come to us saying, I want to make an advanced decision or I want to make a living will, do so because they have supported a family member who they feel had a bad death. And very often that will be a person who is given treatments that perhaps the person calling us feel like they just didn't want. that their end-of-life phase was drawn out when they didn't want it to be. And they call us and they say, how can I stop that happening to me? And how can I make sure that my children don't have to go through the same scenario? And really, it's about being in control of treatment and care, and stopping family members from having to make difficult decisions in times of crisis as well. And I think these are fundamentally just very pragmatic decisions. And a lot of people just don't want to have a drawn-out death. And for them, so not everybody will want to make an advanced decision, but I think there's a surprising amount of people who, given the information about them and the fact that they exist, actually do. And in terms of overall benefit, so we know anecdotally from our services, but there's an increasing body of academic research as well, which shows that advanced decisions can help to reduce unwanted hospital admissions and prevent unnecessary treatments being given. And we find it really improves communication. So the act of making an advanced decision for a lot of the people we support is a catalyst for having sort of really human conversations with their family members about what they want at the end of life. And also it can improve conversations with that person's clinical team as well. And fundamentally, it just helps everybody provide person-centred care because you know what that person wants. So now I'm going to talk about the difference that an advanced decision can make in real terms. So I'm going to talk about two different stories, and one shows what can happen if you don't have an advanced decision, and one shows what can happen if you do have an advanced decision. So this was covered quite a lot at the time. I don't know, some of you might remember, but this is Lindsay and Paul Briggs. And Paul was a Gulf War veteran and a policeman, and he had a young family. And one day when he was travelling home from work, he was knocked off his motorbike and he suffered a traumatic brain injury. And he spent some time in hospital. And after an amount of time, he was diagnosed as being in a minimally conscious state. So he didn't always have awareness of his surroundings. He sometimes showed signs that he might be feeling distressed or in pain. He couldn't feed himself, he couldn't sit up, couldn't interact with his family or anybody at all. And there was agreement from his medical team that there was very little prospect of a meaningful recovery. And Lindsay and Paul had actually talked about this very situation before. And he was very clear with Lindsay that he wouldn't want his life to be prolonged indefinitely in this state. So she felt very clear about what he would want in that situation. But there was a disagreement between the clinical team and the family. And it ended up going to the Court of Protection, which is the court that deals with issues around mental capacity and treatment decisions. And they, in the end, ruled that treatment should be withdrawn and that his wishes should be respected. But it took over 12 months from the time that Lindsay said, actually, I don't think he wants this, I think we need to stop treatment, to treatment actually being withdrawn and him being allowed to die. And Lindsay and her daughter just suffered a lot during that time. And in the ruling, the judge said, if he'd written his wishes in an advanced decision, then none of this procedure would have had to have happened. And Lindsay's now a really, really passionate advocate for advanced care planning. And then this is lovely Elizabeth and Alan. And you can see with this quote here, so with Elizabeth and Alan, he had a heart condition and it started deteriorating. But before it started deteriorating, he made an advanced decision to refuse treatment. And then when his health did start going downhill, he ended up under the care of a different doctor who didn't really know him. And that doctor wanted to admit Alan to hospital and he wanted him to undergo certain treatments. And they both felt very clear because they'd done this advanced care planning and they'd thought through the decisions that he might be faced with when his health deteriorated. They knew what he wanted in that situation and they knew he wanted to stay at home. And Elizabeth talks at length now about how in that situation with a doctor that she didn't know, she felt very, she uses the term bullied, but she found it very difficult to advocate for what he wanted to in a situation when there's such a disparity between technical knowledge and language and levels of understanding. But that categorically, she said, having that advanced decision, and also she had a health LPA as well, gave her the power to advocate for his wishes and ensure that what he wanted was adhered to. But I think which is fantastic, But for me, the really interesting part of this story, which isn't covered on this slide, is that when Elizabeth first contacted Compassion in Dying, she did so in tears. And she called us because Alan had gone to her and said, look, I know what's happening. I'm not going to get any better. Don't want to have I know what's important to my quality of life. I know the point at which actually, you know, if something happens, I don't want to be kept alive and when I have what I would consider to be I think he used the term, a miserable existence. And I just want to be sensible about it and I want to record these wishes. And she was devastated about this. And she called us because she was really scared about what it represented. She wasn't in a place where she was able to acknowledge that Alan was going to die, and she felt very upset about the idea that by agreeing to help him write an advanced decision, she would somehow be signalling to him that she'd given up on him. And so, and they're all completely valid sort of feelings. And so through a series of conversations, we helped to explain what an advanced decision was and that it's actually empowering people and it's about listening to people and it's about listening to what people want and what's most important to people. And she came to see that, and then they went through the process of they both wrote their form, so she now has an advanced decision herself. So that is some examples of what an advanced decision to refuse treatment can, how that can help someone's death. So they're dying, so they're kind of end of life phase. But it's also important to think about the impact that it has, that making one can have for people in the present. So this is from our the monitoring that we do on our information line. And 95% of people say that making an advanced decision gives them peace of mind. 88% say that it makes them feel in control. 86% say that it makes them feel less worried. And I just can't understate the value of that. I mean, I think that's just a lot of words on the page, but it's so powerful and palpable, the relief that people feel when they've gone through the process of recording their wishes, when they have a strong feeling and then they know that they've done that and that's recorded and that their GP has logged it and all the people that need to know about it know. People talk about it being quite freeing, and I think, Zoe, you might have used this term, but it allows people to get on with living well now, basically. So, knowing all of that, why are they so underused? And I'll bring us back to that original stat. There is a typo on this slide, so it's the 76% versus the 7%. And I think there's several barriers, really. There's barriers for the public and barriers for professionals as well that stops people from using advanced decisions when they could benefit from them. In terms of the public, I think there's a lot of misunderstanding. So people tell us that they think it's going to be expensive, that they think it's going to be complicated, that a lot of people, I think because it's often known as a living will, people associate wills with solicitors. A lot of people think that you have to go to a solicitor to make one. And I apologise if there are any solicitors in this room before I say this, but honestly, some of the worst forms that we've seen are ones that are drawn up by solicitors, because you want this form to be, followed in a crisis setting. It needs to be really easily understandable and clinically robust and not open to interpretation and as simple as possible. And solicitors, as brilliant as they aren't always brilliant at doing simple. And there's another one that's not on here, actually, which is what I call the next of kin myth. People, especially in the community engagement work that we do, we'll go to them and we'll talk about advanced decisions and they'll say, great, I totally get it, but I don't need to because my daughter knows what I want. And I think a lot of people don't understand that in a situation where you lack capacity to make decisions for yourself, your family don't automatically have legal decision-making power. And yes, anybody, any clinician making a decision in your best interests will do so and has an ethical obligation to make that decision in your best interests. But there's no way of knowing that what you wanted as an individual is the same as what that person thinks is best for you. But people don't realise that the people who know you best don't necessarily automatically get to make those decisions unless you appoint them as a health attorney. A lot of people don't know about them. And this last one, I think, is a really interesting point. And I think I've worked in end of life for 11, 12 years now, and as a sector, everybody's definitely got better, and I can see society has got better about talking about end of life and planning and wishes, and I do think it's in the public consciousness more than ever with sort of COVID and everything. But there is a tendency to focus on post-death planning, so wills and funerals, and I think that's because it's easier. It's a bit more abstract, isn't it? I mean, it doesn't really affect you because you're dead, effectively, you know, when those things happen. And I think the actual dying bit of end-of-life planning is hard for a lot of people to think about, and it's hard for them to imagine. And so I think that's another reason why people can find it hard to start. And in terms of professionals, so we work a lot with all kinds of different health and social care professionals, and we've recently done some research with GPs on how they feel about advanced decisions, and a lot of what they've said informs what is on this slide. And common things that professionals will say is, I just don't know where I would start with somebody. People are really worried, what if their patients change their mind in the future? How can people know how they'll feel in the future? And I think this is so important to acknowledge. And, you know, Tommy talked brilliantly about burnout earlier, and there's a lot of overlap with this, that doing advanced care planning well takes time, and lots of people just don't have that time. I mean, it really stuck with me. One GP that I spoke to said that they spoke to somebody very recently who they definitely thought could have benefited from making an advanced decision, but they wouldn't start that conversation because starting that conversation would have opened up a whole can of worms, and they just don't have time to do it. And people, I think when you work in a caring capacity and you care for people, you worry about people making serious decisions as well, don't you? And I think there's really good answers to all of these things. So in terms of where to start and not having enough time, there's templates available that can make it very easy, and there's organisations such as Zoe's organisation and Compassion in Dying and My Wishes, you'll hear from James later on, who can help people to go through the process of advanced care planning. I love this thing about what if people change their mind, because people see it as like a really big barrier. You know, how can you get somebody to write an advanced decision? What if they change their mind? Well, good if they change their mind. No one's life stays the same, and these documents absolutely have to be revisited. Just because you write it and it's signed and it's witnessed doesn't mean it's set in stone forever. And through our services, we tell people that they need to revisit it every 2 years or sooner if your health changes. So we actively encourage people to revisit it and check that it still reflects their wishes. And in terms of the worries around how people will know how they'll feel in the future and worries about it being a serious decision, I think that we just need to I think everybody needs to work together to respect people's autonomy, and it's about what's right for each individual. And I think a lot of people are absolutely clear about what their red lines will be and what situations they would want to avoid and what quality of life means for them. And all of that feeds into a really kind of meaningful advanced decision document. So how can we make it easier? I think my answer to this is just that you don't have to start from scratch. So if you're working with someone and you're talking to someone and you think that they might benefit from considering writing an advanced decision, you don't have to start from scratch. So we at Compassion in Dying have an online free advanced decision service. And we first built it in 2016. And it's since then, for that online service, 34,000 people have made an advanced decision through it. And we rebuilt it last year based on feedback from thousands of people. And it's developed in partnership with a range of health and care professionals and academics and legal professionals, and really importantly, patients. So people helped us to build this in a way that works for them. And what this service does is it takes people through the journey of all the things and the reasons why they might lack capacity in the future and asks them what they would want in that situation. And through our sort of many years of supporting people to do this, we have boiled that down to 4 scenarios. And those scenarios are dementia, brain injury, diseases of the central nervous system, and terminal illness. And And we find that for about 98% of people, the scenarios that we've included within the form that people can choose to include if it reflects their wishes, it covers what 98% of people want their advanced decision to cover. There's a lot of guidance throughout to make sure that people understand the decision. So before they even dive into the scenarios, we are very clear about when it will come into effect, and we're clear about what mental capacity means. And this is an example page from the brain injury scenario. And please don't read all of this. But why this slide is here is because I just wanted to convey the amount of guidance that's there for people to dive into. And it's guidance that they can access if they want to. So I always think with the online service that there's an analogy of IKEA furniture. So I don't know about all of you, but when I buy IKEA furniture, will not read the instructions and will just start building it. But then my partner will read all the instructions very diligently. And I think there's a similar approach with digital content, is that the information is there for people to delve into if they want to. But if people don't, there's a basic level of guidance and help and support that will help people to understand what the form is and how to use it. And so we talk about, with every scenario, so brain injury, dementia, diseases of the central nervous system, what those conditions are, what it means, the kind of scenarios that will be covered. And then we ask people, do you want to include this? And they can say yes or no. We also allow people to write their own word their own refusals of treatment if they want to. But we try not to encourage people to do this without support. So if people want to write their own refusal of treatment, we say call us. Just call us and we'll help you to do it. And that's because language is so important when you're writing an advanced decision. You know, I mentioned this earlier, but it needs to be absolutely not open to interpretation and clinically understandable. And it's really hard for somebody to write in that way. And that's why there's support available to help people to do that. So just to give you an example, a common one that we might see people write is, I would like to refuse treatment if I'm in pain, but it's so subjective. There's obviously whole levels of pain. So in terms of a refusal of treatment, that would be very hard to implement. And that's why the support is there to try and help people to do it in an effective way and to really unpick what it means for them and what they're trying to avoid. This is the other bit of the form that I wanted to talk about. So we actually make people do this, so you can't complete the form unless you complete this box. And we ask people, why are you wanting to make this form? And that's because we know from the doctors that we've worked with that, you have someone that presents in front of you with something that there's a number of treatment options you could try before you can make a decision about, their diagnosis or their prognosis. And someone has a form that says, I don't want that. And that's really hard to follow, just emotionally, for a lot of different reasons and professionally. And so we ask people to say, who are you? Why are you writing this form? What is it that you're wanting to avoid? And we know that can make the difference between somebody having the confidence to think, yeah, this person understood the consequences of this decision. I get who this person is. I get why they're making it. This is what their life means to them, and this now makes sense to me. So we find, although this is not a legal requirement, we really encourage people to complete this box because it can make the difference. Is that flashing because I'm late? It's not an alarming timer. It can make the difference between it being followed or not. And also, so we have exactly the same template as a paper form. As Zoe said, there's a huge variation in levels of digital literacy. And so if people want the PDFs, we can post it to them for free. We also have partnerships with a number of NHS trusts and primary care networks and health organisations who white label these forms with their own branding, which we can provide to people if they want them. And you notice we don't have our logo on the front. And that's because, funnily enough, even though this is an advanced decision, some people don't like the word dying, which is not a surprise. So that's me, really, and that's a very whistle-stop tour of advanced decisions. In terms of what to take away from this, just what I said at the beginning and thinking about Lindsay and Paul's story, just that I think that there's and I'm definitely responsible, I'm definitely guilty of this myself with my own family. I think anybody who's caring for somebody, it's really natural to try and to help them and to say, you know, I've got this, don't worry, I'll look after you, I'll care for you. But you can't, and that's the same for professionals as well. And you, just knowing what somebody wants and somebody talking about it, there's absolutely no way that if that person presents in a busy A&E, that you can be sure that the right person is there to convey that information. And so I'm just very, very passionate about supporting people to write these wishes down and record them, because it really can make the difference between it being followed or not when it matters. And advanced decisions are they're really important documents and really simple documents. If somebody feels like there are situations in which they wouldn't want their life prolonged, and then these are really important conversations to have. And I know that the title of my talk is What You Don't Want, and I feel like there's a sort of negative attachment to that. Yeah, I feel like there's a sort of negative attachment to that. And I think really advanced decisions are about human stories. They're talking about what matters to you, and I think that's really important to remember. And lastly, just that there are tools that exist that can help. Thank you.
Thank you so much. And I must say, if anyone hasn't been on to Compassion in Dying, it's really useful because you can go on, I've done mine, I actually have it in my teaching, to actually prove how easy it is to use, and also the amount of information that exists when you're going through it is amazing. And even as healthcare professionals, again, we can all learn something from that. So before we end, is there any questions? Oh, we've got one at the back.
Yeah, online question. Are the Compassion in Dying resources only applicable to the UK, or can they be used outside of the UK?
Oh, that's a great question. They can be used anywhere. How they're interpreted and followed will depend on the law in the jurisdiction that that person's in. So like in lots of countries, there are laws, like very similar laws that put advanced decision-making on a legal footing, so in France, for example. But the answer is absolutely anyone can use it, go for it, but I can't guarantee what the law will say about that in other countries.
Thank you. There's another question at the back there. Thank you.
Yeah, I was just wondering, do they have to be registered anywhere, like with the legal power of a guardians?
Great question.
Yeah.
So they don't have to be registered. So, and I should say that although we have this online service, in England and Wales, the law says you need a wet signature for it to be legally binding. So the online service helps people to create the form, and then you print that at the end and you sign it and get it witnessed. So there isn't anywhere that you need to register it. Just the act of writing it, signing it, dating it, getting it witnessed makes it legally binding, in inverted commas. But that's no good if somebody doesn't know about it. And what we really are campaigning for at Compassion in Dying is a more, I'm laughing as I say this because I feel like it might provoke some groans, but a more joined up, seamless national electronic record system yeah, there you go. Yeah, as we all would like, wouldn't we? To share that decision when it matters, because at the moment it's a postcode lottery. So in London there's quite a good system, in other areas there aren't, and it's just not good enough because, you know, actually we do support a lot of people who go to the trouble of making decisions and then they're not followed because that document wasn't in someone's hand. And it's particularly important and pertinent for people who are very isolated and don't have family. So we say to people, finish it, and then you need to give a copy to your GP, put it on your summary care record, give it to anybody involved in your care. You can send it to your ambulance trust. Most ambulance trusts will record it. You know, anyone who might be phoned if you're in hospital needs to know about it. And that works brilliantly if you have like a daughter next door, or, you know, someone that can turn up at the hospital and wave the form in front of somebody's nose, and that isn't the case for everybody. So there's a long way that we need to go to make sure that they're known about when it matters.
Thanks, Usha. And for Norfolk, we have yellow folders, which we are trying to push out. I'm spying Caroline in the audience there. Yes. So we're trying to push out the yellow folders, and in the yellow folders should have all the important documents, such as advance statement, respect form, advance decision to refuse treatment, what matters most to you, all these things. So hopefully, yes. We've got time for just one more question. I think, sorry, Susie did have a hand up at the first. Can you pass it down?
I've got it already. That was really interesting, thank you. I'm a patient, so I'm not coming from the same angle as just about everyone else here. But I've got a respect form up to date and in place, and both my LPAs. Would you suggest this was like a belt and braces approach, so I've got everything, or have I gone a bit overboard?
Oh, it's a really good question. I don't think you can go overboard. I think that, firstly, in terms of the LPA and the advanced decision, they can really complement each other. So a really common thing we hear is somebody will phone up and say, OK, I've done my LPA, I've got both my kids as my attorneys. They know what I want, but I'm really worried that if something happens, and in a really, really stressful situation, life or death situation, the doctor says, what should we do? They like to put them in that scenario of having to make the decision to refuse treatment is a massive burden. So to help them with that, I'm also going to do an advanced decision. And then if I'm in a scenario that's covered by my advanced decision, then that's it. That needs to be followed. And then anything else that happens, your attorneys can make decisions. And in terms of the respect form, I think, again, they're really complementary. I mean, it's just, it's obviously not an ideal scenario to have 3 different forms that all do a similar thing, but that's the world we live in. And I think that at the moment, if you can do them all, if you have wishes that are relevant to each of them, then do it. Yeah, thanks.
Thanks for that, Susie, and I would echo that, because I think it's just like the house model. It's all about the foundations, finding out what matters most, which is the conversation, and then having those important documents, which is very much who is your voice, what you do want and kind of what you don't want in your statement of wishes, and then definitely, again, what you don't want and what you do want in your advanced decision to refuse treatment. And then to bring it all together, what do we do in an emergency, which for us here in Norfolk is your respect. So definitely advocate. It's a whole kind of package. Thank you so much, Isha. So next I'd love to welcome to the stage, again, another fabulous speaker. I'm going to have to use different words because last year I was using amazing all the time, so I've got to kind of change that. So I'd love to welcome to the stage Wayne Martin, who is the Professor of Philosophy for the Autonomy Project. It's the amazing one. If you haven't seen it online, do have a look. And he is from the University of Essex. Welcome.
Great. Thank you so much, Danny, and to all the organizers. I know so much work has gone in to all of this. So, what an amazing, extraordinary morning. I expect your minds are starting to turn to lunch. My job is to get you to think about cardiac arrest instead. So let's see. I need to figure out how to use this. There we go. There's me. So as Danny says, I'm a philosopher by training and I guess by temperament. I'm not from around here, as you can probably tell, but I've been at the University of Essex for about 20 years now, and I direct a project called the Essex Autonomy Project. Some of you may know it. I like to reassure people it's not a liberation movement for Essex men. It's a research and public policy initiative that focuses on respect for autonomy and human rights, particularly in care situations. So this kind of stuff is our bread and butter. And I have 1,000 questions for Usha and for Zoe and for other people in here, so I look forward to pursuing those questions over lunch. I'm gonna report here today on some research, that we got started on during COVID. As you may remember, at the height of COVID, there was a lot of concern about abuse of DNA CPR forms. There was a Care Quality Commission investigation of that. They called for more research, more training, more guidance. And together with some people in this room, notably Carolyn Barry, we've been answering that call. So I'll just give you a bit of a glimpse of that, and then you can go have lunch. So ethical and dilemmas in DNA CPR decisions. So first of all, acronym busters. Civil servants and doctors love acronyms, so I'm sure you all know this already, but just to be clear, CPR stands for cardiopulmonary resuscitation. DNA CPR stands for do not attempt cardiopulmonary resuscitation. We'll get to some other acronyms that crop up in this space in a few minutes. I think it's useful to use that full one if you're going to use an acronym. It is interesting, reflecting just on Usha's remarks too, that we always talk about DNA CPR. Nobody ever talks about ACPR. Attempt cardiopulmonary resuscitation. And actually, we've just been involved in an appeal in the Court of Appeals where somebody really wanted more heroic measures to be undertaken than the doctors really were inclined to provide. So maybe we need an ACPR form as well. It's interesting too, in terms of ADRTs, here we go, we've now been trained up on that, advanced decisions to refuse treatment. Again, there's a priority on the negative there. And one thing that we need to talk about with Usha and get her advice about is, how do I go about making sure where it's not a refusal, but an authorization that is what is really important to me. So I think it's really important not to lose sight of that. So I'm going to talk about some of our research findings. This is kind of the primary research basis for what I'm going to talk about. That thing on the left there is the CQC report that came out at the height of COVID in response to quite a lot of concern around potential abuse. People talked about blanket DNA CPRs being used. Up there on the right, Sabine Michalowski is my lawyer colleague, and so we did some research around that. And then I'm also going to give you some results from some survey data that we undertook. So I'm going to divide my remarks here into two parts. And I'm going to start by talking about the practice of DNA CPR. And then that's the most important thing. Part of my thesis here is there's a lot of misunderstanding around that, even among experts. And then if we have time, I want to spend a little bit of time educating people here about the situation where CPR decisions have to be taken in circumstances where there is no DNA CPR form, because that's also, we're realizing, a source of problems and friction. So I find it useful to think about DNA CPRs in terms of three phases in the life of a CPR. First of all, there's that phase where somebody's completing a DNA CPR form. That might be at a point of admission, for example, or a point of transfer. And so that's stage one. Hopefully there's some consultation that happens at that stage, although we know oftentimes that doesn't take place. Then there's the stage where it lies fallow for a long time. It's in a filing cabinet or it's in somebody's medical file someplace. There's no need for it. And then there's an acute moment when it has to be used. And so a decision has to be made in really, like right now. There's no time for deliberation. Hopefully at the first stage of the life of a DNA CPR, there's time for some reflection, for some conversations, for consulting with family members and so on. At the last stage, there's no time for consulting with anybody, so you better have a pretty clear plan of action about what's going to happen. And then we know at each stage, things can go wrong. The most common thing that goes wrong at the first stage is a DNA CPR form is put in people's files with no consultation. With very, very few exceptions, that's unlawful. The courts have been very clear about that, so that's the most common thing that goes wrong there. Things can be stored in ways that nobody has access to, and so you put all this work into something and then, it's gone. And then I'll get in a minute to the ways in which things can go wrong at that moment of acute decision making. So we need to think clearly about all three of those phases in thinking about DNA CPR. Okay, here we go. Now, ready for quizzes? This is a test for you. Here in England and Wales, I speak not for other jurisdictions, there are in fact 3 available legal bases for clinical treatment of an adult. If you are treating somebody, you better have a legal basis for doing it, or you are opening yourself for trouble. And really, there are only 3. If we had more time, I would challenge you to name them. Think about it. Here we go. Here's the answer. One is informed consent. That's the common law, right? An adult is treated on the basis of informed consent. They say, yes, you can cut me up with a knife. Normally, that would be assault, but here, that counts as treatment. My informed consent is the magical transformation that makes that difference. So that's the primary and most common one. It's funny, in America, you get a consent form for absolutely everything because everybody's afraid of being sued. Here, it's fairly rare to ask somebody actually to sign a consent form, but we take consent all the time, and that's the legal basis under which we are operating. There is then, of course, the special case of a Mental Health Act section that's only authorizing treatment for a mental disorder of a nature and degree such that the person is a danger to themselves or other, but that's another legal basis for medical treatment. And then the third one is the Mental Capacity Act. A person is found unable to make their own decisions for the matter at hand, and then a best interest decision is made, okay? So those are the 3, and as far as I know, only 3 possible legal bases for legal treatment. Shelley Farnan, our colleague at the NHS England, she has a thing behind her Zoom board. It says, what's the legal basis for what you're doing? And if it's not one of those 3, you better pause and think again. So the next question is, which of these 3 is the legal basis for the initiation of cardiopulmonary resuscitation? It's going to have to be incapacity plus best interests, right? It's not treatment for a mental health disorder. The person sort of ipso facto is not able to provide their informed consent. You're not going to seek consent to do CPR in a situation of cardiac arrest. So we're talking about the Mental Capacity Act. I mean, it seems a little odd because, of course, you're not going to do a formal capacity assessment in this situation, but you are instantaneously going to come to the judgment, this person does not have the ability to make this decision, so I've reached the judgment reasonably, the law is big on reasonably, that it's in their best interest to initiate CPR. Okay, so the governing legal framework for CPR is the mental capacity framework. Does that make sense? You with me? Good. Okay, onward then. That's the kind of legal background. Onto my thesis, I've already adumbrated it. CPR and DNA CPR is very widely misunderstood, even among experts. And actually, I think if my one lesson here is today, we need to foster better understanding about it, because a lot of the conflict in this zone, and there is a lot of conflict in this zone, I think comes about because of misunderstandings. So that's what we've been trying to do, and I'll share you some resources at the end about that. Okay, here we go. You ready? This really is a quiz now. True or false? Raise your hand. CPR should never be performed if there's a valid DNA CPR in place. Think for a minute. Who thinks that's true? We get a little more light text? Yeah. Raise them high so we can see. There we go. Who thinks that's false? Okay. So here's a little survey we did, 1,084 participants at a National Mental Capacity Forum webinar on this topic. This is something that Caroline and I worked on together. And you can see there's some difference of opinion, just like in this room, but the substantial majority of the respondents thought that was true, but it's not. What's the answer here? DNA CPR, legally speaking, is a recommendation, not an order. And if you work for a trust where that form says DNA CPR order at the top of it, you should lobby to have that changed. Or better yet, you should lobby to get rid of standalone DNA CPRs and have respect instead, because that's better. Yay! So really, legally speaking, what you're doing with a DNA CPR recommendation, let's all learn to use that, is you're anticipating a point where a best interest decision is going to need to be made. And you're trying, as a care provider, to provide assistance to that person who's going to have to make it in a hurry. But that person at the time may have information that you don't have, in which case they might decide to do something different. So it's a recommendation, not an order. It informs, but does not bind clinical decision, okay? Next one, true or false? The primary purpose of a DNA CPR consultation is to gain consent from the patient before adding a DNA CPR to their medical records. Think about it. How many people think that's true? How many people think that's false? It's that same 1,000-person. See, again, a very substantial difference of opinion. By the way, these were people who are joining up to a webinar from the National Mental Capacity Forum. These are overwhelmingly what we call capacity professionals. They're care providers or other professionals who have play a part of their responsibility is to apply the Mental Capacity Act. So these people ought to be in the know. Again, a plurality think that's true, not quite 50%. But there's a very substantial group that think that's false, and that is false, okay? That's not true. The DNA CPR is not a consent-based intervention. I'll get to in a minute why that's the case. One more, I think, on our true and false test. True or false? A doctor does not need the consent of the patient or those close to them to place a DNA CPR in their medical records. I've already given you a clue about that. How many people think that's true? How many people think that's false? So there, about half thought that was false in our survey, but in fact, it's true, okay? So the crucial thing here is that a DNA CPR recommendation, it needs to take into account what the law calls the wishes and feelings, the beliefs and values of the person, but it does not require the consent of the person. And this goes back to the issue about legal basis for CPR. CPR is not a consent-based intervention. It's based on the Mental Capacity Act. It's a best interest judgment for somebody who can't make the decision for themselves. And in a best interest procedure, you take into account the wishes and feelings, beliefs and values of the person, but you might see fit to diverge from them, okay? So this is not a consent-based intervention. It's amazing the extent of the misunderstanding about that. You'll find lots and lots of patients and family members who will say, I was asked to sign a DNA CPR form and I refused. But there is no place on the DNA CPR form for the patient's signature, right? It's a doctor-initiated procedure, typically. So it's different from the advanced refusals, decisions to refuse treatment. That's a patient-initiated procedure, and that does need to be signed in the case if it's a refusal of life-saving treatment. DNA CPRs are not like that. The only signature field there is going to be from a clinician, typically, okay? All right, so I hope I've demonstrated my thesis. First of all, most of those experts were getting the wrong answer, and some of you did too. So there's very wide misunderstanding. And you are the experts, people, right? You are the people coming to an advanced care planning conference here and tuning in online. So imagine the degree of misunderstanding among the general population. So we need to do better, I think, in educating the public about what these are all about. They are important. They get a lot of bad press. The right-wing press hates them. But boy, you need to be able not to always initiate CPR, as we'll see here as we go on. Okay, so let's move on then. I mean, we're, again, focusing on that first phase in the life of a DNA CPR. We're talking about that moment where something is, a recommendation is adopted. And one of the principal sort of imperatives there is consult, consult, consult. Talk to the person. If they lack capacity, talk to a family member, get informants, find out what their wishes and feelings are, a message that's come up a lot already today. But what's the aim or the purpose of consultation prior to adopting a DNA CPR recommendation? The courts say you need to consult, but what are you doing in that consultation? As we've seen, you're not seeking consent. That's not what it's about. So if you're a care professional, how do you or would you go about that kind of consultation? What are you aiming to accomplish in that meeting? Well, it turns out the answer to that question is rather complicated, and partly that's because lawyers came up with it. So the law recognizes two distinct grounds for DNA CPR recommendations. And this is in that article that Sabine Mikulowski and I covered, but it's also in some good national guidance from the Research Council. In one case, the recommendation is based on a judgment that there's no reasonable prospect of success. We talked to a bunch of paramedics about this when we were working on it. For paramedics, you always initiate CPR unless, and then there's a short list of exceptions. And any paramedics here today? There we go. So one of the places you don't have to initiate CPR, according to the National Paramedics Guidance, is if the accident victim is decapitated. You're off the hook for CPR if the patient is decapitated, but otherwise you start. But anyway, that's a case, no reasonable prospect of success, right? That's but also if you're in a situation where a person is actively dying, Caroline has some lovely ways of talking about this clinically that I find really useful. Is the heart the first thing that's giving out here, or is it the last thing along a chain of organ collapse, right? If there's no reasonable prospect of success, then you would recommend don't initiate CPR, right? That's just going to, at best, extend the dying process or also render it more painful than it needs to be, less dignified than it could be. So that would be one legally recognized ground, it's a clinical judgment, really, about the prospects of success. And the other is there may be some prospect of success. And actually how you define success here is tricky. Are we just talking about starting the heart for how long? Or are we talking about a prospect for actually discharge from whatever facility you're in? That's a tricky area. That's a different, so there might be some prospect of success, but the burdens of initiating it just don't outweigh the benefits. The chances of reaping those benefits are slim, and the costs of the intervention are going to be very high. It's a very forceful, by definition, intervention. So that's one thing you got to be clear about, right? If you're making a DNA CPR recommendation, which of these two grounds is your basis for it? You should pause and ask yourself that. And if you're somebody who's involved in filling out these forms, you should make sure that it is clearly indicated on that form which of these two is the grounds for that recommendation. And if you work for a trust that doesn't have a field that asks that question, then you should be lobbying for them to revise the form so it's very clear that the form prompts that choice of those two, or better yet, adopt respect instead. Now, depending on which of those two grounds you're adopting, the purpose of the consultation differs, okay? So this is really based on a key court of appeal case. If it's one of those no reasonable prospects of success, that's really a clinical judgment, yeah? That's a judgment that only really a doctor is going to be able to make. Or a clinician, clinically trained professional. And then the purpose of the consultation is to inform the patient or the family members, the case may be if they lack capacity, including informing them of their right to seek a second opinion. But if the grounds of the recommendation is that the burdens are likely to outweigh the benefits, we're in a really different zone. We're now in a mental capacity best interest zone. Medical considerations are one set of considerations that are relevant, but it's really a much broader ethical judgment about what all things is best for you, given all these different considerations. So there you want to educate, you want to get the person's perspective, you want to seek to determine the relevant wishes and feelings, beliefs and values. That's the language of the capacity process you'll recognize. So two different grounds, two different purposes and aims in that consultation process. There is one little buyout where the courts have recognized that you might not consult, but it's so narrow that I'm not going to talk about it. Okay, here we go. And there's another quiz for you. What's the 30-day survival rate of nursing home residents following CPR? 30 days alive after 30 days after CPR. I should say those two studies, I'm not aware of a study on this in England and Wales. Those are both from other jurisdictions. If anybody knows of a study of that here, I'd be interested to know. Tiny, tiny, tiny chance of success, okay? That's a really relevant piece of information in weighing up the pros and cons of the benefits and harms associated with CPR. And I take it from the murmur in the room that even you experts probably didn't know about that. Here we go, warning. The public is badly misled by TV CPR, right? If you watch medical programs, except, I guess, I'm told Grey's Anatomy is better. More people die in CPR episodes in Grey's Anatomy than any other medical television program. But even there, it's like way too high a survival rate. So people have this idea about CPR based on what they've seen on television, including professionals, that is wildly out of sync with the reality. There's actually a lovely little sort of research industry now. It is getting better. There's a trend towards more realism, but it's still very, very far from the actual thing. Okay, so far I've been talking about the first stage in the phase in the life of a DNA CPR form, about when consultation is needed, basically always, and what you're doing in that consultation, the way that varies depending on the grounds. But let's now talk about the third stage. There's an interesting question about storing it. I don't have anything to say about that, but it's another thing we should really be putting our heads together around. But using a DNA CPR form in acute decision-making. And so we did a survey of care professionals. So these are, again, what we call capacity professionals. These are care professionals whose job description involves, in one way or another, applying the Mental Capacity Act in care practice. And we were zeroing in, for this study, this was done during COVID, on capacity professionals who were working in or with locked down care homes, okay? So that was the group here. And one of the questions in that survey, it's a smaller group, 262, it's still a fairly large number for this kind of study. We asked them, I have witnessed CPR influence medical decisions beyond CPR. And you can see here, 17%. It's not a huge number, but it's not a tiny number either. That's a pretty good wedge of that pie. They said, yes, I have witnessed that. Now look, DNA CPR recommendations, the clue is in the name, right? It's meant to be a recommendation about one kind of medical intervention. It's to aid the person at that acute moment in deciding whether or not to initiate CPR. But in fact, we know that it's being used for other purposes. And those who answered yes to that question, we gave them a free text area to report on that. And you can find that as a QR code if you're interested. I guess you'll get the slides later, or go look for the Autonomy Project online. All these papers are on our website. Here's some of the responses. We call this mission creep, right? The mission of the DNA CPR form is to provide assistance to the person about this one medical intervention, but it gets used as a proxy for other decisions. So here we go. I should have brought my glasses. Some staff, so these are, again, free text responses on this survey. Some staff see DNR as do not care or do not seek any medical treatment. A DNA CPR is, according to this participant, about CPR, but also it's about antibiotics. It's about hospital treatment, it's about fluid, it's about anything that's a sustaining treatment. It's also sometimes used as a way of managing end of life and whether people want to remain in the care home or be admitted to hospital. And I just think it's really badly understood by professionals, some professionals. Anyway, there was a story that was covered recently, well, it was about a year ago now, about a guy who was choking in a care home. Some of you will be aware of this story. And the care home staff called an ambulance. There was nobody on duty who had been trained on the Heimlich maneuver. There was no cardiac episode at all. And there's tape of the 911 call, or whatever we call it here, 999 call. And they respond and they give it a top ranking, priority 1 to send an ambulance out. But then they say, stay on the line. And as they stay on the line, it comes out this person has a DNA CPR form in his file. And so it's downgraded to a 3. Totally irrelevant. And of course, 3, that person never saw an ambulance. Okay, I'm coming towards the end. It's lunchtime. Terminology matters. Here's one of my take-homes. Let's call it a DNA CPR recommendation. Correct people if you hear them talking about it as an order. It is not an order, and we know there's very widespread misunderstanding around that. Let's call it by DNA CPR. DNAR means do not attempt resuscitation, and there are other forms of resuscitation, and this recommendation does not apply to them, so it's misleading to call it DNR. Worse yet, do not resuscitate. These are, I would like to banish, or if that's what you mean, do not resuscitate, don't attempt any resuscitation, then put that down, right? Let's say that completely. Don't use, that's a dangerous acronym. Again, it would be one thing if we knew everybody had a good understanding of this, but we don't. We know people don't have a good understanding about this, so avoid the misleading acronyms. We prefer to talk about ceilings of treatment, not about ceilings of care. This relates to Tommy's representation this morning. There is no ceiling of care. Keep caring all the way up, keep going. But there are ceilings of treatment. Again, respect is the right. If what you want to do is to put in some recommendations about ceilings of treatment, respect is the tool for that, not a DNA CPR. That's just for one decision. And then I was going to talk about the difference between these two things, but Usha's done such a great job. ADRT, an advanced decision to refuse treatment, is different from a DNA CPR recommendation. As Usha emphasized, an ADRT, an advanced decision to refuse treatment, is binding if it's valid and applicable, and it's person-led. It's the patient is really leading on that. DNA CPR is not binding, it's a recommendation, and it is clinician-led. We must be coming out to the end of time. Yeah, so I'm going to skip the rest of this. There is a public policy challenge we all face right now about the circumstance where people do not have a DNA CPR form in their file, they don't have a respect form in their file, and a CPR decision needs to be made. And right now, frontline care professionals are getting into professional trouble about that, including for not initiating CPR on people who are clearly dead. So anyway, that's a topic for another occasion. Thank you.
Thank you so much. We've got like 1 minute for one quick question online, okay?
It's quite a long question. How does placing a DNA CPR in the medical records after a patient has
Could you
stayed?
slow down a little bit? Sorry.
I was trying to get it in before lunch.
I know, but I have to understand it.
How does placing a DNA CPR in the medical records after a patient has stated, after a lengthy discussion with you, that they would like to be resuscitated, practically work? Whilst you have already discussed this, are you subsequently legally bound to explain to the patient that despite their wishes, you have decided to put such a record in their notes?
Great, yes. So, a difficult topic and a subject of a looming Court of Appeal hearing, I think you'll find, sort of a Court of Appeal ruling. The hearing has already taken place. So we will be getting some guidance from the Court of Appeal on questions related to that. But the short answer is, for better or for worse, nobody has a right to demand medical treatment from a physician who thinks it's inappropriate to provide it. So if the clinician determines that it is not in your best interest to have CPR, you have no right to expect it. You do have a right to seek a second opinion. Okay, we had to condense all of this into 1.5-minute videos, so check that out and tell me what you think about it. These are meant to be accessible to a wide variety of service users and service providers. Thank you.